Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight we're going to be talking about coronary artery disease, or CAD, and brachytherapy with interventional cardiologist J.P. Reilly. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 504-866-3200. We'll have that at the bottom of our screen throughout the second part of our program. Or you can send us questions by email, like 3 of you have already done, at hhquestions@wlae.com. We'll ask you to hold off on the phone calls for a while, but you can send those email questions straight away. Well, tonight on the program, we welcome cardiologist J.P. Reilly. Dr. Reilly received his medical degree from Columbia University in New York City. That's the area he's from. He completed his internship, residency, and cardiology fellowship at the New York University Medical Center before completing another fellowship in interventional cardiology at the Scripps Clinic in San Diego, California. Dr. Reilly is board certified in internal medicine, cardiovascular diseases, and in interventional cardiology, as we mentioned, and specializes in complex coronary and peripheral intervention, carotid stenting, valvuloplasty, limb salvage, and renovascular hypertension. He also serves as the vice chairman of Ochsner's Department of Cardiology, and we are pleased to welcome to the program for the first time Dr. J.P. Reilly. Good to have you on the program, Doctor.
Tom, thanks very much for having me. Appreciate it.
You've been here in the New Orleans area now for a little more than a dozen years, you and your family, and your wife's from even further than the New York area, right? Tell us about your family and what you think of the area and how you ended up here.
So you're right, my wife's from England, and we have 3 little kids that we've raised here. And they keep reminding us that although we're from somewhere else, they're from here.
This is their home. Yeah. Talk to me about how you got started in medicine and how you ended up in the specialty of cardiology.
Well, in medical school, I actually found cardiology both very interesting and very challenging. I think initially that was the element of physiology that I found the most challenging and the part that I wanted to conquer, so to speak, which is why I then was really drawn to it.
Good. Well, we're glad you've chosen to stay here in New Orleans, move here, and stick around. So thank you for that investment in our community. Let's start with a definition. Coronary artery disease, or CAD, is what exactly?
Coronary artery disease is the buildup of plaque, which consists of cholesterol deposits, as well as some inflammatory cells, some scar tissue, and calcium, which combine to form obstructions in the arteries of our heart. You can see from the graphic there, the picture on the left, all the way to the left-hand side of that panel, you see the arteries that we're born with, which are wide open and beautiful and healthy. The little white dots are the cholesterol molecules that are then floating through our arteries as we go through life, picking up hamburgers and McDonald's, and not to pick on any one restaurant. but those cholesterol molecules start getting deposited in the walls of our arteries, and that little dark storm about halfway down the artery is what we call plaque rupture. And that plaque rupture leads to further growth of the obstruction until it's finally blocking flow through our arteries, which are meant to be delivering blood and oxygen and nutrients to our heart muscle, which is beating along all day long, every day.
So if the plumber comes to my house and uses his imaging or puts something down the pipe and says, boy, let me tell you, you got all sorts of crud in there and this thing needs to be cleaned out, you know, a little liquid plumber, Drano, again, not to use any specific one, but it'd be easy enough to clear all that out. Not as easy with the arteries.
It's not as easy with the arteries, exactly. We don't have a liquid solution that we can just pour down the arteries to open them up, unfortunately. But like our drains, we probably have a little bit of plaque that we can tolerate, that the drain will still effectively empty the sink. But at some point, it becomes so obstructive that the sink backs up, it won't empty out, and we've got to do something mechanical about it.
Is the plaque going to build up at various levels depending on different people? So we could both be 52 years old, but yours could be clean and green and mine could be a mess.
You're absolutely right. And I think some people think of it as just part of getting older or being American, that we're going to develop plaque in our arteries and we'll get as gray as I've gotten now. And that's not true for everybody. Not everybody goes gray. Not everybody develops plaque. In fact, the prevalence of coronary artery disease is only about 6.5% in the United States. So while it's common, and we kind of all know somebody who has it, it's not going to happen to all of us. And it depends on a lot of factors into who's going to develop heart disease and who's not.
All right. I'd take the gray, by the way, just for what it's worth. Who's primarily at risk for coronary artery disease? You said meant 6%, but do we know who's in that 6%?
Right. So there are a lot of people who are at higher risk for developing coronary artery disease. So people who are smokers, people who are not up and active and exercising, people with bad diets, people with hypertension, people with diabetes, and people with high cholesterol. These are all risk factors that will predispose people to coronary artery disease. There's also some genetic components to coronary artery disease, and so people who know that they have heart disease running in their family may be more likely to develop heart disease or more likely to develop it at younger ages. Those all go into determining who may develop coronary artery disease. But it's true that I see some people who we can't find any identifiable risk factor, and they will still have significant blockages, while other people somehow are getting away with doing one or more of those things who have yet developed any blockages.
Would a patient necessarily know they have coronary artery disease? Are there symptoms?
So there are symptoms, but in the graphic we showed earlier, that process of developing plaque takes place over years. And in fact, that plaque first starts getting deposited in our 20s or 30s and may not become manifested with symptoms until 20 years later, when that plaque has grown enough to actually slow flow down the artery. Lots of people may have coronary artery disease and not know it yet. Not to worry, if it's only 20 or 30, 40% blocked and not restricting flow, it's probably not damaging us yet, and we have time to change our lifestyle and try and prevent that blockage from growing.
You brought some pictures along of some patients that'll give you an idea of some of the symptoms folks might be experiencing.
So once we do start developing symptoms, most people describe it like the gentleman who's on the left, who doesn't look like he's in particularly bad pain. It's not Fred Stanford staggering down the stairs.
Here comes the big one.
That's right.
That's not it.
He looks uncomfortable. He'll correct me and say, no, it's not painful. It's just discomfort. It's a pressure in my chest. It's a tightness. And that's sort of the classic description of anginal chest pain. Mm-hmm. Some people, like the man in the middle, may say, no, it's more like if I could just belch, I'd get rid of this. I feel nauseated. I feel like I've got indigestion. And some of those people that's an atypical but common presentation of heart disease. Mm-hmm. Other common associated symptoms are a discomfort or pain that radiates up to their shoulder, usually the left arm or left shoulder, and sometimes up into their jaw. They may also feel a tightness in their jaw. And those are the most common symptoms.
Shortness of breath, could we add that in?
That's a great point. Shortness of breath may also be associated as a symptom of coronary disease, although there are other reasons that make us short of breath. As we put on a little bit of weight or become deconditioned and don't exercise as much, We might find it harder to keep up with our kids as we're walking through the supermarket or going up a flight of stairs. And I think that if you're somebody who encounters a level of exertion that you could typically do, if normally you walk up 1 or 2 flights of stairs to your job or to home and you're not getting short of breath, you've been doing that for years, but now over the last couple of weeks, suddenly that's making you short of breath, that's a change, and that may be a symptom then of coronary disease.
Okay. Let's talk about diagnosing CAD. Someone comes to see a doctor, watches this program tonight, has some of the symptoms you've described, maybe has a family history. What are you going to do to diagnose? You can't just see it from the outside.
Right. We don't have the Star Trek instrument yet to be able to see that. But if we, for people who are having symptoms, then the stress test is probably the most effective way for assessing people whether their symptoms are probably related to an obstruction that's tight enough to restrict flow and be producing their symptoms. Stress tests are done a couple different ways. For people who are able to exercise at a treadmill, those are very effective stress tests. But some people have balance issues or orthopedic reasons why they may not be able to keep up on a treadmill. And so we have other ways of simulating exercise in order to be able to do a stress test. Now, some people don't have symptoms yet, but they may want to know what the risk for coronary artery disease is. They should talk to their primary care doctor or their cardiologist. And another test is called a coronary calcium score may be appropriate for them.
It's a blood test?
The coronary calcium score is actually a CAT scan test. It doesn't need any contrast dye, but they have a very quick low radiation dose CT scan that is actually able to quantify the calcium in the arteries. I mentioned some of the elements that go into depositing plaque into the arteries: cholesterol, some scar tissue. Calcium is part of that scar tissue that gets developed. And so the CT scan is able to quantify exactly how much calcium is there, which is correlates directly with how much plaque is building up there.
Angiogram still considered the gold standard. When would you need, is that the last thing? Obviously that's a little more invasive, a little more risky. At what point would you use an angiogram?
So you're right, angiograms still are the gold standard test. So for people who have significant abnormalities on a stress test, they may merit going on and having an angiogram to see what the next best step in their treatment is. For people who have a sudden onset of symptoms, for people who are actively having a heart attack or who appear to be on the verge of having a heart attack, those people may also need to go directly to having an angiogram instead of having a stress test or coronary calcium score first.
Is it, have we gotten to the point today where you're already in with the angiogram? Can you do any repair work there at the same time?
Yes, so the angiogram is actually the diagnostic part of the test that leads directly to laying the map, so to speak, for doing the angioplasty and a stent placement. And we do often now do, as we call, ad hoc angioplasty, where we find a lesion, it's the lesion we were expecting and a lesion that we think we're going to be able to help someone's symptoms, and we may go ahead and fix them with a stent directly. Now, some people, when we do the angiogram, we find out they need only medical therapy, or maybe they need bypass surgery. And for those people, they'll get referred to go have bypass surgery, or we will stop and talk with them about their lifestyle modification and medications.
Okay, leads us nicely into treatment options for coronary artery disease.
And so I think the last one I mentioned, I should have mentioned first, because the lifestyle modification, eating right, exercising, that's the first thing. The next, almost all patients with coronary artery disease are going to need medications, and that will be medications that are going to lower cholesterol, make sure blood pressure is under control, etc. The image on the right there is a CAT scan that's creating a CT angiogram. It's an angiogram of a heart that has already had bypass surgery, and you can see the artery coming straight down. That's a bypass graft onto the front of the heart, and another one onto the sidewall of the heart, and that is a bypass surgery for certain patients is the most appropriate treatment. But on the next slide, you'll see that we have stenting may be an appropriate treatment for other people. On the left panel there, the arrow is pointing to a little light area in that in the contrast dye going down the artery in the front wall, and that's a blockage in the left anterior descending artery. The middle panel, you'll recognize the pencil, but the little metal tube just above it is a coronary stent, and that shows you how small these stents are. That stent then gets implanted into the artery and acts as scaffolding to prop the artery open. And on the next slide, you'll see a cartoon that sort of shows at the top there, number one shows an artery with blockage. The yellow inside the artery displays the cholesterol plaque that's building up. A small thin wire is advanced through our catheter across the blockage, and the stent is mounted down onto a balloon. It's crimped down onto the balloon. It's positioned in the precise spot where the blockage is. Once the balloon is expanded, the stent expands with it. We then can deflate the balloon, remove the balloon and the wire, but the stainless steel stent has been expanded and stays open in place to prop that artery open.
Pluses to the stent process and minuses to the stent process. How effective are they?
So the stents are very effective. As we said, they can be done as sort of ad hoc. When we do an angiogram and identify a blockage, we may be able to fix that blockage there in the appropriate patients. The recovery is fairly straightforward. People go home the following morning, if not sometimes the same day. So the recovery process is very simple. And on the next slide, you'll see, I pointed out that stents have been a big boon compared to angioplasty without stents. In the days 20 years ago, in angioplasty without stents, 1 in 3 people may have had problems with their angioplasty and had to go back to have another angiogram or angioplasty, and some people right to the operating room. Stents, that scaffolding helps prop that artery open. On the left side, you'll see the EKG at the top shows a patient who's having a acute myocardial infarction who's in the midst of a heart attack. And this chart at the bottom shows that stents, the bar on the left, had patients who had stents to stop their heart attack, had a much better outcome, much lower event rate of dying, having another heart attack, having a stroke, compared to people who are being treated with just angioplasty alone, which is why taking people directly to the cath lab for stent treatment is the best treatment. For people who come in, thankfully, more electively, who are not in the midst of a heart attack, medications do a very good job of treating many of those people who have what we call stable angina. The people have been having the same level of pain or discomfort for a few months. However, the patients who have angioplasty and stenting typically have fewer symptoms over the first year or 3 years in a trial called the COURAGE trial, compared to people who are just being treated with medications alone.
Before we get to the video we're going to show of the stenting process and some of the limitations of stents, are there now plaque-busting drugs? So we talked about we can't use the liquid. It's not as simple as liquid plumber. But are there drugs that can actually reduce that plaque? Have we made that progress yet? Are there any foods, or we keep hearing that's healthy maybe to have a glass of wine or a glass of beer per evening? Are any of those things moving us in the right direction and actually cleaning out, maybe not completely, but moving us in the right direction?
Well, a glass of wine, alcohol in moderation certainly is helpful and beneficial. Good news to many people in New Orleans. But what drugs that we call statin drugs are very good, and they're very effective at stabilizing plaque, preventing heart attacks, preventing strokes. And that stabilization of the plaque, in the earlier cartoon I showed you, I alluded to that dark storm cloud kind of erupting and plaque rupture. We don't want the plaque rupture. That's when people suddenly have onset of symptoms. That's what causes the heart attacks. If we can stabilize the plaque and keep that storm cloud from erupting, we're winning the battle there. So if we have a 50% blockage and our statin is able to keep it there, we're winning the game. Our drugs are getting better. We are starting to see some regression.
In plaque. In the plaque.
In the plaque.
Right, yeah.
In the plaque as well. I think it's not as good as many of us and many of my patients would like it to be. A blockage in the heart artery only has to be about 75% blocked. It can be as much as 75% blocked before it's obstructing. And the analogy I often use is a garden hose. You want to try and pinch it off and cover it up, but you have to have it almost all the way pinched off before the water will stop. Right? Same thing with your heart artery. It's got to be more than 75% blocked before it's really obstructing. When I tell people they've got a 50% blockage or a 60% blockage, they want it out and they want it all gone. We don't have drugs that are going to do that. They're going to take a 50 or 60% blockage down to nothing.
Right.
If we get what we call a 10% relative reduction, right? So take a 60% blockage, take away 10% of it, and you go to the sale, 10% sounds big. When only $6 comes off the $100 item, it doesn't seem so big. So when the 6% comes off the 60, that doesn't sound as encouraging. But I do think it's encouraging because we're making progress. I think eventually we'll get the drug that will help resorb the plaque, but enough. But we're not there. We're not quite there yet. But we are making progress.
And there are any cautionary notes that you would want to sound about statins, or someone who came in and said, "Doctor, hey, I hear this is the miracle drug. A lot of people are taking them now. Obviously, they have benefits, or you wouldn't have brought it up."
Right.
But any cautionary notes that you would use with your patients?
Well, if there are people who have liver disease, we're going to be cautious with that class of drugs, with statin drugs. People have to be aware that they may develop what we call a myositis, some muscular discomfort when they take statins, but the majority of patients get tremendous benefit from taking statins. And so for my patients with CAD, I will ask them to take a statin, and if they fail one, I may try other statins to find out what works, because I think in the end, large-scale studies have proven that the more people with CAD that you can successfully treat with statins, the better their outcomes are going to be. There may be some people who are not going to be able to tolerate or have a liver disorder that keeps them from taking it, and then we'll work around those. But we want to try and get as many people on statins.
And liver function is something that would be monitored by a primary care physician, or would that be a specialist? Or either way, it's important that liver function would be monitored.
Either
correct?
way, the primary care doctor is going to take care of it. If a cardiologist puts you on a statin, they'll take responsibility of, at the times when they're checking routine blood work, their liver test will go along with that. But it's not something that necessarily needs to see a liver specialist for every person who takes a statin.
Right. And final thought on statins. You talked about the rain cloud, the storm, because the plaque's there, not really causing an issue. There's a breakage, and that's what leads to the issues. What about someone who's at 20 or 30%, maybe not at high risk, but all it takes is a small piece to break off? What about on a preventive side of taking statins before I'm even fully diagnosed with CAD?
Right. So the person who's at so the primary prevention, we call that primary prevention. Mm-hmm. So people who we've proven have coronary artery disease, who've already had an event and have had a heart attack, they should all take statins. Primary prevention, there are many people who are at high risk for coronary disease because they may have multiple risk factors that we talked about earlier, smoking or family history or high cholesterol. And if that puts them at high risk, then they should take a statin as well. Patients who are at very low risk, they're very young, there's no family history, there's probably not benefit for taking statins for them. And if the coronary calcium score that we talked about earlier may help push people into one group or another, know who's at higher risk or not at higher risk.
Great points. Our guest is interventional cardiologist J.P. Reilly, and tonight we're talking about coronary artery disease, or CAD, and brachytherapy in just a moment as a way to treat CAD. Doctor, you brought along a couple of videos, and let's take a look at the first one now. And what are we going to see in this one?
Well, we're going to talk a little bit about some of the limitations of stent. I'm an interventional cardiologist, and that's what I do, and I don't want to oversell them. They're not for everybody, and there are some lesions or patients in whom it can be challenging to put stents, or bypass surgery medications are more appropriate. And the first video shows an angiogram of a patient who's actually had bypass surgery before, but you see this blockage occurs at a branching point. There's a shadow just north of the catheter there. That dark shadow there is dense calcification, which is also a challenge for placing a stent. And these are some of the technical limitations why we may come back to the patient and say, we weren't able to put a stent in this case because of the calcification, because it supplied two arteries at one spot, or in this left main artery also.
Then we have a side-by-side image to show folks as well.
But once we've put a stent, one of the major limitations for stenting has been scar tissue formation. Exactly. On the left, you see that's a chest scar, but you may know somebody who has a keloid type of scar, this hyperplastic scarring effect, and it's disfiguring when it's on the surface of the skin. But in the panel on the right there, you can see little bits of metal poking out there, but all that yellow is the scar tissue that has formed in response to the stent. And when the stent is inside your heart artery, there's no place for that scar tissue to develop but except to intrude onto the lumen, the area where the
blockage
right
in some cases.
Right. So we put the stent in, it turns out fine, but maybe 3 months or 6 months or a year later, some scar tissue has developed and is now restricting blood flow again. When we first started using stents about 20 years ago, 25 years ago, scar tissue was even a bigger limitation than it is today. And we may see scar tissue in as many as 20 or 25% of people who had a stent placed, that it was obstructive enough that they may need a repeat treatment.
Has the technology improved, or we just know how to put them in better? What's gotten better?
So our next slide shows how our technology has improved, because we've over the last 10 or 15 years, we've had a drug implanted, embedded on the stent itself. And these drug-eluting stents, the drug that we put on them inhibits the scar tissue formation. So you see in the red bar is the rate of events for patients who had the bare metal stent. The smaller blue bars are the drug-eluting stents there. TLR is target lesion revascularization. TVF is target vessel failure. And so that's the target vessel or target lesion is the spot that we wanted to treat. We put the stent in. And if we put a drug-eluting stent, you see that on the left, only 5% of people needed to have that area retreated compared to 20% of people who had the bare metal stent. Mm-hmm. And the target vessel failure was looking at the whole artery. It was 10 compared to 25. MACE is major adverse cardiac event. That's either being retreated with another angioplasty or bypass surgery, heart attacks, dying, stroke. That's MACE. Mm-hmm. And you see that was lower in the patients with the drug-eluting stents compared to bare metal stent. So about a 50% reduction in the events, although not quite zero. We're, just like we talked about, have some improvement in the plaque, but we're not able to kind of get it back down to zero yet.
Okay. So what's going to happen if a patient comes to see you? And we're going to talk about brachytherapy in just a moment. We've got another video to show you too as well. But what's going to happen? First step, I come to see you and I'm diagnosed with CAD.
So you've been diagnosed with CAD, and if you've had significantly limiting symptoms, or you have a significantly abnormal stress test, you'll probably need an angiogram then. You know, if you've been diagnosed with CAD but you're asymptomatic, you can run 10 minutes on a treadmill during a stress test, then as we talked before, we're probably going to just focus on risk factor reduction. But let's imagine you're having lots of symptoms or your stress was very abnormal. We'll do an angiogram. If we find a blockage that we think would account for those symptoms, and that a stent is going to be readily deployed, and open up that blockage, and get a good result, then most likely we'll implant that stent. You'll go home, and then we'll watch you carefully. You'll still have to take the medications. You'll still have to be aware of adjusting your lifestyle, whatever your foibles may be.
Right.
And but you'll be followed up closely, and should those symptoms recur, investigate again with another stress test or maybe another angiogram or maybe different forms of treatment of the blockage.
Very good. We're going to come back and take your questions in a couple of minutes. We're talking about coronary artery disease, and our guest tonight is interventional cardiologist J.P. Reilly. Phone number to call us, and you can call us right now at 504-866-3200. That's 504-866-3200, or you can send us questions by email. We've already got some at hhquestions@wlae.com. Again, we'll get to those questions in a moment. But Doctor, tell us about the Scripps trial and what that's about and how it's helping patients with CAD.
Well, we talked before about the scar tissue and how that was a very frequent recurrence. Mm-hmm. And there were some people who had recalcitrant restenosis. Just it kept recurring. It got a repeat angioplasty. The scar tissue came back. Very discouraging for a lot of people. So brachytherapy was developed, and that was treating the scar tissue inside these heart stents the same way we would treat, as you said, similar to cancer, similar to excessive keloid formation, has also been treated with radiation therapy. And the Scripps trial looked at the effectiveness of treating this scar tissue inside the coronary arteries with radiation therapy compared to treating it with just balloon angioplasty or stenting.
Yeah, you brought some more graphics here and numbers to show us.
Yes.
It'll help illustrate this.
So the blue bar is the placebo, meaning they no additional treatment, just the balloon angioplasty. The orange or reddish bar there is labeled IR192. That's the radiation source, iridium 192, which show that a lower rate of recurrence of restenosis inside the stent in the two bars on the left by about 29%, reduction of the scar tissue formation inside the lesion by about 22% there. And those p-values are 0.1, which means they are not quite statistically significant. However, the target lesion revascularization, we talked about that earlier, whether there was enough scar tissue formation in there that it needs to have a repeat angioplasty or a repeat bypass on there. And you see there's a 44% reduction for the patients who got radiation therapy compared to the people who got balloon angioplasty alone. And that p-value was significant, less than 0.01. And the table on the next slide will show you that those first four lines, death, non-cardiac death, MI, Q wave MI, and non-Q wave MI, I guess those first 5 lines, those are safety markers. The p-value is NS, not significant. So we were able to give the radiation therapy, the first column, iridium 192, without any difference in death or heart attack, because those safety markers were all the same. TVR, that effectiveness marker that we've been talking about, target vessel revascularization, that was significantly lower. Only 41% of these patients who received the radiation therapy needed repeat revascularization, compared to more than 60% of the people who were treated with just balloon alone.
So brachytherapy is something you're using to deliver the radiation. We've talked about it being an effective treatment option for cancer patients, and now with coronary artery disease. And you brought along another video to show us exactly how that's done. And
you're right. And the video here is to point out that it's done in a manner that's very similar to a regular balloon angioplasty procedure. You'll see the shadow here before we put it in is a long segment of stent in the artery in the front wall of the heart, the LAD. Down near the end of that stent, there's an obstruction, and after this angiogram loops one more time, we're going to see the balloon angioplasty there. The balloon is inflated over the wire to stretch open the scar tissue that's inside the stent. The next step is take a catheter. Here, you see a marker above and below there, and that is the catheter that is delivering the radiation therapy. The solid line between those two markers is actually the source delivering the radiation. It's then going to get returned back and removed, as you see it slide back out of the artery there. And that's the radiation source being removed in the artery. It sits in there for about 3 minutes to deliver the radiation therapy. The radiation therapy doesn't itself burn away or dissolve away the scar tissue. The balloon mechanically stretches it open. What the radiation therapy does, just like it does in cancer, is keeps those cells from continuing to divide and reform scar tissue there. So once we balloon it open, once we deliver that radiation therapy, all that equipment comes out, and as you said, it's very effective in about a 30% to 40% reduction in the rate of people needing another angioplasty or another treatment for that again.
All right. Been a fascinating first half of our program. You're the star of the next half. You'll be back with your questions in just a moment. Our phone number is 504-866-3200. That's 866-3200 again. Or you can email questions to us at hhquestions@wlae.com. We'll be back with your questions in a moment. This is Hello Health on WLAE.
Did you know kids who play outdoors have healthier lungs?
Totally.
Did you know that boys that play with dolls make better husbands?
My son has lots of dolls. But did you know terry cloth diapers breathe better?
I did.
It's totally true.
Oh, yeah.
Did you guys know statistically friendly kids have more friends?
Yeah.
That's obvious.
Did you know most people think they're using the right car seat for their kid, but they're not? Parents who really know it all know for sure that their child is in the right seat. Visit safercar.gov/the-right-seat to make sure your child is protected.
I needed help finding a doctor.
PACE.
I needed help with my medication.
PACE.
I needed help getting around.
The Shirley Landry Benson PACE Center is a place that helps seniors remain in their homes, providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
They say that when you're facing extreme danger, your life flashes before you. If you think that's sad, consider facing it before you even have enough life to flash before your eyes. Deaths and injuries can be prevented by using the right car seat. Visit safercar.gov/the-right-seat to know what is appropriate for each age and size.
And welcome back to Hello Health on WLAE. Tonight we're talking about coronary artery disease, CAD, and treatment options, including brachytherapy. Interventional cardiologist J.P. Reilly is our guest. And let's go to your questions now. Let's start on line one. Linda calling us from New Orleans. Linda, welcome to Hello Health. You're first.
Hi.
Hi, good evening.
Linda.
Go right ahead, Linda.
My husband is 70. He had a heart attack in 2000, and he has not been under a cardiologist all this time, and I actually just got him to go to see one in the appointment is on the 31st at Oxnard with Dr. Patrick. And he has a stent in his main artery. Don't that need to be checked to make sure that there's no build-up, no plaque, no blockage still could have occurred in all these years?
So, Linda, it's great that you've got him coming in to see a cardiologist. I think it's important for people who've had any coronary event to see a cardiologist regularly, to keep track of that. Stents don't necessarily have to be checked from the point of view of repeat angiograms on a routine basis, but I think certainly keeping track of them about whether people have recurrence of the symptom that they had prior to their heart attack or prior to their stent is very important. Many patients who have high-risk lesions have their stents in high-risk portions of their arteries, meaning a lot of their heart muscles in jeopardy. They may need to have routine stress testing, although we don't think that people need to have a stress test every year just because they're a coronary patient. Probably once every 3 years for the patients who are at the highest risk for events is a good surveillance system for people with coronary artery disease.
Okay, Linda, thank you so much, and good luck to your husband, and thank you for your call. Let's go back to our phones, line 2. Renee calling us from St. Rose this evening. Renee, you're next, and you're on Hello Health.
Hi, my name is Renee, and Hello?
Yes, go right ahead, Renee. Go ahead with your
hi.
question.
My question is this. I had an angiogram done, too, about in 2010. And I want to know, I guess you kind of answered my question from the last caller. How often should I have the stress test done? And that's the first question. And my second question is this. When you take statin medicine, like when I take my statin medicine, which is Lipitor, and I have pains extremely bad in my left leg when I do take it. But my doctor said that I have to take it to keep my cholesterol down. So do you think that's a blockage there? Okay.
So it's a two-part question, Linda. The first question is, I think it depends on what they found on your angiogram. Some people may have an angiogram and the physician may find no blockage. You may have normal arteries, which would be good, and in which case you would not be unlikely to need another angiogram in the near future. If you did have, I didn't hear whether you said you had had a stent or not, but as I told the previous caller, if you have had a stent, at most you probably need to have a stress test if your symptoms haven't recurred. Now, coming to your statin medication, I think statins are very important for people with coronary artery disease, and if you can tolerate taking them, I think all patients with coronary artery disease should take their statin medication. Some people do develop discomfort in the muscles, usually of their thighs, their legs, due to statin medicines. One of the blood tests your doctor has may be able to give an indication about whether or not that is inflammation in the muscle due to the statin or not, and that may be a reason why your physician is saying that it is or isn't related to your statin medication. Blockages in your arteries of your legs may cause symptoms, but that wouldn't be because of the statin. But the blockages in your heart arteries may also develop blockages in the other arteries of our body, like our carotid arteries or the arteries of our legs. And another test is called an ankle brachial index, or an ABI. It is a simple non-invasive test that can be readily done to assess whether that symptom in your leg is due to a blockage in the artery there.
Doctor, earlier in your earlier presentation, you talked about some people tolerate some statins better than others. So there may be other options. The doctor might be saying you need to stay on statins, but maybe not necessarily that one. Have you found that with some of your patients?
I have found that. I have found that some people are more tolerant of one statin versus another statin, and there are some pharmacological differences for why that may be true. Atorvastatin, which is Lipitor, has some of the greatest effectiveness data, which is why it's so commonly used. But we can try and solve that problem for people who are not tolerating atorvastatin.
All right. Renee, thank you for your call. Our phone number, 504-866-3200. That's 866-3200. Tonight we're talking about coronary artery disease with interventional cardiologist J.P. Reilly. Let's go to line 3. Floyd is calling us from Houma this evening. Floyd, you're on with Dr. Reilly. Go right ahead.
Hi, Dr. Reilly. How you doing?
I'm well. How you doing, Floyd?
Well, you did an angiogram on me about 6 months ago, and it was, I must say, a most pleasant experience out of all the other experiences I've had over there. And the two guys that was doing the fellowship with you was almost, it was a comedy team. But the best part about the procedure is that you went up the wrist. And I hadn't had anything like that before out of the other procedures I had, and it was almost a pleasant experience. I didn't feel anything. I was in a twilight zone. I heard y'all talking all the way through, and I must say I was very impressed with it.
Floyd, thank you very much, and you can keep calling as many times as you like. I appreciate you. Thanks for saying so. An angiogram being done from the radial artery, we're doing more commonly these days. It is a safer procedure compared to the femoral artery because we're able to prevent bleeding more easily for procedures that are done from the radial artery. We can do the angiogram, and if needed, we can put the stent in with an angiogram done from the radial artery. Floyd may be overstating it a little bit. I'm not sure it's enjoyable. I'm not sure you would choose an angiogram over a night out to dinner with your spouse probably, but it is. It's more comfortable because people can sit up directly after the procedure. Historically, when people have had angiograms from the artery at the top of your hip there, the femoral artery, they had to lay flat for several hours after, which made it difficult to eat or drink afterward. Patients with a radial artery angiogram can sit up right after, eat and drink right after, so it is much more comfortable as well.
All right. Floyd, thank you for calling and sharing your story tonight. And if you'd like to do the same, whether you have a question or not, please feel free to give us a call here at 504-866-3200. Edgar, calling us from New Orleans, is next on line 4. Welcome, Edgar. Good to have you with us.
Hello?
Yes, Edgar. Go right ahead.
I'd like to know if a vegetarian or a vegan diet coupled with moderate exercise, that minimize, I have a stent already, will that minimize my chances of having another stent?
Edgar, thanks very much. So I think that really highlights some of the importance of lifestyle modification Many people, unfortunately, regard having their bypass operation or their stent placement as being a cure for their coronary artery disease. As we talked about earlier, this plaque has been developing often for 20 years or more before we get to the point where we need a bypass operation or a stent. And those same factors that were causing that cholesterol to be deposited in our heart arteries are not removed by that surgical procedure or by that stent procedure. And so lowering our dietary fat or switching to a vegetarian or vegan diet may be necessary for some people. I absolutely do think that you're doing a great job of increasing your exercise and changing your diet to lower the likelihood of needing other procedures in the future. So congratulations. I think that making that big change is hard for many people. And so I got to congratulate you a lot.
Thanks, Edgar. We appreciate the call and congratulations. Line 5, we're going to Covington next, where Robert is with us. Robert, you're on with Dr. Reilly. Go right ahead.
Dr. Reilly, are all of the Ochsner cath labs able to perform the radiation procedure on the stent set of block? And second question, can a stent be removed and replaced? I'm going to turn off my phone and listen.
Okay. Thank you very much, Robert. Very good questions. The stents actually don't get removed or replaced. You saw from the picture earlier how big the stent is compared to the pencil. What you're not able to see is how thin the walls, the struts of those stents are, which are 0.054 millimeters. Okay? So they're very thin walled. So in those cases where a stent is having a problem and there's too much scar tissue, sometimes we treat those with repeat stenting and just put one stent inside the other stent. And that's the analogy I often use. It's like putting another coat of paint on the wall. I mean, each layer is so thin. However, some people have that scar tissue recurring, and for which we offer the radiation therapy. We don't have that at all the Ochsner centers, actually. We have that at Jefferson Highway.
Main campus.
The main campus.
Right.
Because we have the infrastructure supporting that there. Mm-hmm. We have the radiation oncologists there as well, and their physicists who help us with managing the radiation source and the dosing of the radiation, which is important also. So we don't have it in all the facilities, but all of your cardiologists in those other facilities know that we have it and can identify the patients who will benefit the most from it and refer them to us.
Good questions. Thank you so much. We appreciate you asking them. 504-866-3200 is our number. Chester's next, calling us from Pearl River this evening. Chester, you're on with Dr. Reilly.
Yeah, hi, thanks. Listen, I had an angiogram when I was 58 and had several blockages and had quadruple bypass surgery. Now I'm 65, and I was just curious, is it possible to put stents in bypass arteries or grafts, or is that something, medication or another operation is the only option for me?
No, Chester, for people who have had bypass surgery before and then develop recurrence or symptoms or their stress test is abnormal again, we can put stents inside bypass grafts. That is something that we can do and we frequently do. Sometimes people who've had bypass surgery have a blockage in one of their own arteries that is a new blockage and not necessarily being treated by their bypasses, which may be open or may have closed in the interim, and then their own arteries may need a stent also. But both can be done even after a bypass operation.
All right, Chester, I hope that's good news. Let's go to line 2. Matilda next, calling us from Mississippi in Waveland. Matilda, welcome. You're on Hello Health.
Thank you, and how do you do? I'm having a little confusion. I have no chest pain. I have no tightness in my chest. But for the last year, or a few months less, when I stoop over and I stand up, I feel like I'm going to pass out. I kind of black out. If I'm in the grocery store, I have to hold on to the grocery basket till I get my bearings. I do have appointments made from primary doctor, and we'll go from there. But I don't want to go and start a whole lot of things if this is normal, or what do you think about this, doctor? I've had a mastectomy of the left breast 5 years ago, and I've really been through a lot. And I don't want to get into anything if this is just normal. Could you give me some help and tell me?
I'll try, Matilda. It's well, it's not normal to be almost passing out. You know, that's never normal. And even though it's maybe happening frequently to you, it is something that should get checked out because we don't want almost passing out to turn into actually passing out. It would not be a typical symptom for coronary artery disease, but some other forms of heart disease may be related to this. It may be related to something more general that we would call autonomic dysfunction, where we're not regulating ourselves as well to change the position as we did before. But I think it is definitely something you should have checked out.
All right, Matilda, thank you. Hopefully we've given you some good direction here this evening. We received lots of emails tonight, and we'll get to as many as we possibly can. Here it is, Doctor. Can anything be done when some arteries are calcified, especially when these arteries have stents that have collapsed already?
So I mentioned before that sometimes arteries are very heavily calcified. It makes it difficult to expand or implant stents. We do have some particular devices that are similar to a dentist drill that we can use to treat that calcium and basically drill bits of that calcium out to make the artery a little bit more pliable again. That may allow us to implant a stent. If you've already had a stent implanted inside that artery, that may make it more challenging. Sometimes we may treat that with a drill again. The stents do not typically collapse themselves. The stents are made out of stainless steel or some other metal. They don't typically collapse. We sometimes refer to them as having scar tissue formation. Sometimes a clot may form inside them. Sometimes the stent may keep it from completely sometimes the calcium may have kept that stent from completely expanding in the first place. That can always be challenging to treat afterward. Some people need bypass surgery because the calcium is so dense that we can't treat it with a stent. But sometimes there are things we can do with the stents that are trying to manage heavy calcium through a balloon and stent procedure.
Okay, back to our phones. Line 1, Mike calling from Laranger this evening. Mike, you're on with Dr. J.P. Reilly.
Hello, Dr. Reilly. Thanks for taking my call. I want to thank you, Dr. Reilly, for taking care of me in April. You did the angiogram on me also through the wrist and was the femoral artery. And I didn't have any blockages, but you were doing some measuring of my aortic valve, which I have aortic valve stenosis. And Dr. Perino has, I'm 14 weeks post-op with the valve changed to a porcine valve, and he did some ascending aortic repair. Question I got, a couple questions. One is I'm having a little back problem, and I want to try an inverted table, and I guess it's okay for me to hang upside down. So I'll let you answer that for me because I want to kind of get this back going because everything else is working great. And if you would talk about TAVR, the catheterization valve change in case. I'm doing pretty good, so I think I might make it till I wear this one out. So I might need a new valve, and I'll stand by and listen. Thank you very much.
I'm sorry, but the second part of your question was about PAD?
TAVR, Doc.
TAVR. Yeah.
Yeah.
Sure. So, okay, great. So I think that 14 weeks after your aortic valve surgery, Dr. Perino, I imagine, has seen you, and at over 3 months has probably felt you've healed well enough from that surgery. I think back treatment, like inversion, is probably okay. He would have told you whether something having to do with your chest, like push-ups or lifting with barbells, he would have specifically cleared you about that. So I think your back treatment will probably be okay. He or his nurse would always be willing to take your call. I know Gene really well. Our kids go to school together. They'd be happy to answer that specific question for you if you needed it. TAVR is another great, whole exciting topic, transcatheter aortic valve replacement. And so for people who are not good candidates for aortic valve surgery, which you've already had, we're able to offer a valve that gets implanted through a catheter, generally from the femoral artery, because the catheter is maybe the size of my ring finger or so. That gets in smaller than that. My pinky maybe now. The technology is improving. And so the valve gets implanted up through the femoral artery and gets deployed inside the previous valve. And they do sometimes do a valve-in-valve TAVR procedure. So maybe you've just had your porcine valve, that if in 10 or 15 years that has problems, I imagine the technology will be at a place where you will get a TAVR instead of an open heart procedure at that time.
Exciting. Doctor, another email here. A 35-year-old pack-a-day smoker, female with high blood pressure, had it since I was 19, have controlled type 2 diabetes and high cholesterol. Father died of a stroke, grandmother died of congestive heart failure, grandpa died of a massive heart attack. Those were maternal grandparents, by the way. My dad's brother had a pacemaker. Mom is being tested for heart failure. Am I at high risk for heart disease? This is from Esther. Esther, thank you for your question.
Esther, that's a challenging question, a challenging situation. You are at high risk for heart disease. You have several of the risk factors that we talked about earlier. Many of your family members have had atherosclerotic disease, coronary artery disease, so you are probably at higher risk. You're currently a smoker, which certainly puts people at significantly higher risk for coronary artery disease than people who don't smoke. Importantly, also the diabetes you mentioned. People who've been diagnosed with diabetes are at the same risk of having a heart attack over the next 5 years as somebody who's already had a heart attack. So we call diabetes a coronary risk equivalent. Okay, so we would treat you as aggressively as somebody who I put a stent in today, or who presented with a heart attack today. Your young age means that that's in your favor. It's generally 35-year-old women don't have heart disease yet, but I think that because these other things that you can change, smoking, smoking and getting control of your diabetes, I think are critical for you.
If this was a family member of yours, you would be advising her to see someone quickly, though.
I would come in. If you have not been seeing a primary care doctor, I would definitely see a primary care doctor, get a real assessment of risk factor reduction, and discussion of what lifestyle modifications you need to make, whether or not you need to increase your exercise or lose weight, changing your diet, and then probably some medications.
All right. I want to thank Dr. Reilly for the education and information he's provided tonight and for his continued work in the Ochsner Health System. Doctor, thank you so much. Great to have you with us on the program.
It's been a pleasure, Tom.
Thank you again for being in our city and for investing here in New Orleans. Well, we want to thank you, too, for some great calls and great questions tonight. To make an appointment with any Ochsner physician, including tonight's guest, Dr. J.P. Reilly, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at this special number. It's just for viewers of this program, 842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on our website at WLAE.com, or you can go to Ochsner's website at ochsner.org. Thanks again to tonight's guest. Thanks to Humana and Ochsner for making this program possible. And our final thanks, as always, is to you for your support of our program Hello Health and our station, WLAE.
Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.